privileged to be the chair of the scientific program of this 2013 biennial meeting of AORTIC here in Durban. And we have worked with the local organizing committee and our central office in Cape Town, with Lindeni, with Belmore and others, to provide a well-balanced and rich program involving everybody working around cancer, like the cancer advocate, the palliative care specialist, the specialist, the clinical oncologist, the biologist, the radiation oncologist, and I might forget some of them, but anyone working on cancer, even the cancer survivors are here, and the NGOs and stakeholders to try to put cancer on the African agenda. I do think that some kind of interventional action that can be taken to reduce the burden of cancer in Africa, and mainly in the three top cancers, meaning the cervical cancer in women, the breast cancer in women, and the prostate cancer. We are having a lot of symposia and a lot of panel discussion around cervical cancer, vaccination, prevention, early detection. The problem concerning screening or mass screening is the availability of treatment in some regions. Like when you have available treatment in your country, you can propose to patient mass screening, because if you have any early diagnosis, you can propose a treatment. But unfortunately, when you go out and you tell to patients, so the population come out, we're going to screen you for any cancer, and then, well, we had identified cancer, what to do next? Well, nothing to do, because you cannot do anything. That turned to be unethical. That's why we mainly talking about early detection in some cancers like prostate cancer rather than mass screening. But for the cervical cancer, I do think that doing screening in the population is very good, because we can definitely act very quickly to reduce the mortality related to cervical cancer, the mortality and morbidity related to breast cancer, but the mortality related to prostate cancer too. There are other cancers like childhood cancer. They are having good program now in hematological cancer. And unfortunately, in some places like Eastern and Southern Africa, we are having more and more HIV-related cancers that should be addressed too. We have, I'm a urologist, uro-oncologist, so I'm more comfortable to talk specifically about prostate cancer. We are having a lot of action, a lot of work being done around consortia. We have now one consortium that was set at AORTIC in 2009 in Tanzania, called MADCAP, the Men of African Descent in Carcinoma of the Prostate, which is led by a good friend of me, Timothy Robeck from Pennsylvania. And now we managed to include many institutions in South Africa. We have Witwatersrand in Johannesburg, Tygerberg, we have Botswana, Uganda, we have Nigeria, Ghana, we have Sudan, Senegal, and now we have included the Caribbean, the Bahamas, Jamaica, and we are having like 5 or 6 institutions in the United States that will help develop common projects and set up international collaboration, but a win-win collaboration. The other thing what is happening is we are providing more and more treatment to patients in Africa, because they are coming much earlier than it used to be. They still come late, but the proportion of patients coming early is much better now than it used to be 10 years ago. So those patients that are diagnosed very early are amenable to radical treatment, and especially to radical prostatectomy. And we have centers, few centers, but we have centers now providing radical surgery to those patients. And we are definitely dedicated to training other people in other African regions to be able to provide radical prostatectomy to patients. The main problem now is radiation therapy, because of lack of equipment, because of lack of human resources. Unfortunately, patients are not benefiting, especially at the early stage, on all the effects of the radiation oncology now. I think we should work together with the AORTIC, the other stakeholders, the partners, working with some universities to be able to provide all the services around what I call the AORTIC Initiative for Cancer Training in Africa. And that should be great at the time. Yeah, I think that the very best thing, very first thing they have to take away is having the opportunity to networking, because most of them are not privileged to travel like we do. But coming to AORTIC and meeting everybody at the same time, WHO is here, UICC, having INCA friends, having NCI in the United States, having many universities present here, is a very good opportunity for African researchers to meet them and to set up collaboration, which is first thing. Second thing is that all those people should be advocate for cancer awareness in their country when they go home. And the take-home message will be how to find specific African solution for African problem as far as cancer is concerned.